Good afternoon, everyone. I'm Professor Athol Johnston, a clinical pharmacologist and forensic toxicologist, and a member of the Royal College of Pathologists Special Advisory Committee on Toxicology. Thank you very much for joining today's webinar, Learning Lessons from Coroner's Reports and the Preventable Death Tracker. Today's webinar will be up to 1 hour and will include a short presentation by our speaker, Dr. Georgia Richards. Dr. Richards is an epidemiologist, a healthcare research scientist, and a King's Prize Research Fellow at King's College London. She's founded and leads the Preventable Death Tracker, a national vigilance platform that collates and analyses coroner's reports to learn lessons following inquests. There'll be a short Q&A after the session, and to ask a question, please use the Q&A function, which will either be at the top or bottom of your screen, and someone will pick that up. The webinar is being recorded and uploaded to the RC Path website in the coming weeks. So if you miss anything, you'll be able to pick that up. Attendees can self-credit 1 CPD point for attending today's webinar. So over to Georgia and Dr. Richards, and she'll tell us what the Preventable Death Tracker is, for I'm sure a lot of you don't understand what it is or why we need it. Georgia, thank you.
Wonderful. Good afternoon, everyone, and thanks for joining this webinar on a very warm afternoon in the UK. So I wanted to start by saying that most of this work I created the Preventable Deaths Tracker about 5 years ago during my PhD at the University of Oxford. However, all the work I've done over the last sort of 5 years has been completely unfunded. And so it's been a real passion project of mine that I've been working on from PhD student into postdoc and various other roles at Oxford and outside of Oxford until this year I was fortunate enough to receive the King's Prize Fellowship. So I've now officially moved over to King's College London, and King's has now given me the first organisation that's actually funding my research and is now funding the Preventable Deaths Tracker. So I've just started at King's, so this presentation today will be looking sort of back at what the tracker is, how we created it, all the work that we've done to date that's been completely unfunded, and then hopefully at the end I'll talk about the future work that I hope to do and where I hope to take this now that I have properly received funding and will be supported to deliver and work on this no longer just a passion project type of project that I can present to you today. So that's sort of an introduction around funding and my move from Oxford to King's College London. So to begin, I thought I'd start with sharing just some data to contextualize what the tracker is and what its role is. So this is the latest data that's been published from ONS from last year to show the number of deaths that were registered in England and Wales. So just under 600,000 deaths occurred over the last year in England and Wales. Of all those deaths, about 66% or 2/3 of those deaths don't have an actual death investigation. Now there is a new medical examiner system, which is slightly changing this. However, we think of sort of black and white. We have 2/3 of deaths that don't get referred to the coroner and 1/3 of deaths, or 34% of all deaths last year, that do get referred and reported onto the coroner. So last year, this was just under 200,000 deaths that were reported to the coroner. We then have inquests. So if the cause of death cannot be determined, an inquest will be opened by a coroner in a local area. There are about 80 coroner areas across the country, across England and Wales. And last year in 2023, just under 37,000 inquests were open, which represents about 6% of all deaths. And then there are legislation and laws in England and Wales which mandate that a coroner writes a PFD, or a prevention of future death report, when the coroner deems that there are lessons to prevent future deaths. These reports are sent to different organisations who the coroner deems have the power to take action. These reports, or these people that receive these reports, have 56 days to respond to the coroner. They then, the coroner then sends that report and the responses to those reports to the chief coroner's office. The chief coroner's office then publishes those reports and responses when they come through onto an open government website, the judiciary website. And so I came across this website back in 2018 when colleagues of mine who are clinical pharmacologists were working on these reports to look at medicine-related deaths. My question when I started looking into these reports were around, well, how many deaths have been prevented now that this system is in place to share these reports, put them up online? What system is in place to actually look at preventable deaths? And I couldn't determine that number. And this is sort of just to go back in time, what the websites looked like and what I was working with. So back in 2018, 2019, when I was building the tracker, it was a sort of website on the left. It was sort of just text and PDF documents uploaded onto a website. Since August 2022, there has been a sort of change in this website, and it has certainly improved, and you can search, but it is still very limited in terms of actually analyzing this data and knowing anything around statistics on these reports. So that's why back in end of 2020, I launched and started the Preventable Deaths Tracker to actually form a database behind these coroner reports. And now, because we have this database, we can actually share statistics, which didn't exist up until the last 2 years and until the tracker, obviously, but there was no national statistics on these reports. So now we can look in real time to see how many reports were published last year because we have this database. So last year there was 546 reports published. We can use that to calculate statistics, like what's the median number of reports that are published each year. So it's a very small number, only about 467 reports are published each year in England and Wales, which represents less than 0.1% of all deaths, which represents 1.5% of all inquests. So a very small number of deaths that get referred to the coroner that end in an inquest actually get one of these reports written. We've also built the first and only way to consolidate and analyze responses from coroner reports. And I'll talk more about this later on, but we now have a statistic on how many people respond to the coroner. It used to sit at about 33%, or 1 in every 3 report had a response. Now this is increased a lot to 47%, which is exciting. However, this should be 100% by law. So all organizations should respond. All those responses should be published on to the chief coroner's website. However, it is up to the discretion of the chief coroner to determine if they will or won't publish these reports as well. But this level is very low in terms of what the legislation requires organizations and the chief coroner's office to do. So what is the tracker? It is a data-driven learning and vigilance platform that collects all published reports and makes them usable for research and analytics. So it is an openly available website that anyone can access anywhere in the world. It's created off a computer program that goes onto the judiciary website, collects all of the information. What we've really been working on the last few years is cleaning that information and standardizing that information for over 5,000 reports that have been published to date. And this sort of cleaning and processing allows us to produce real-time statistics and a database that contains now over 11 years of data of all the coroner reports published in the last 11 years. This is what the main database looks like. We have improved and changed this over time. The sort of last improvement to this database was now there is this sort of status bar. So we can, with one look, we can type in a coroner area and we can see how many responses are pending, how many, which means they're within the 56 days of waiting for a response, how many are completed. So all of the organizations that were sent reports have actually sent a response. Those that may be overdue, so they haven't yet responded to the coroner and there is no response published. Those that may be partial, so that's where you might get 2 or 3 or 4 organizations who received a report, but only 1 or 2 of those have responded. And we also have some cases from 2013 to 2015, the sort of earlier data where there is not enough robust data around organizations that were sent these reports. So we don't have data to share on those. But that only works out to be about 17% of all cases in the database. So this is the primary database that we have access, that we present on the website. So this database and the analytics are updated every single Sunday at 5 p.m. So the data is always up to date. And this allows us to provide real-time insights into trends, geographical variations, coroner variations across the country, and response rates to these reports. Alternatively, there are coroner statistics that are published every year. That comes out in May of every year, but our data allows us to be done in real time at the end of every single week. On the database page, you can see trends over time, so you can hover over the different years to get real-time statistics. The reason that these numbers change is, and I'll talk more about this when I get onto responses, is we worked with coroners over December, January of this year, where we did an audit of different areas and different coroners to see how many reports were missing from the website. From the judiciary website. So they hadn't been published by the Chief Coroner's Office. There's many reasons for why they might not have been published, because this data at the moment is just shared via email addresses. So what we often find is these sort of trends over time change because old reports are being published online from 5 years ago, from 4 years ago. So this data and this analytics platform allows us to monitor these changes in real time. But importantly, it also allows us to look at sort of just general statistics. We now know that there's 467 PFDs are published annually, and that average rate changes every week with more reports that are published each week. We can also see in real time how many reports have been published just in 2024 alone, 331 at the moment. We can also look at coronal variation. And so before the tracker existed, no one knew what coroners were writing reports, where they were writing reports, who was writing reports. Not even the chief coroner knew who was writing them, where they were being written. So now in real time, we can look to see what coroners are actually writing these reports and also what coroners are not writing these reports. Coroners aren't used to people looking into and analyzing their data. So this is sort of the first platform that has actually done that and just analyzing publicly available information. It's not a leaderboard. It's not trying to compare different coroners. It's just showing you the data that's available and the analyses that can be done with information that's already sitting there, just not used in the most efficient way. We can map that by geographical variation to look at how this might change across the country. And so we have a map and various other ways that you can interact with that data. What we find over and over again is that coroners in Greater Manchester South and Inner North London write the most reports. What hasn't yet been done is to bring together other and link other data sets to analyze to see, is it because there's just more deaths that are occurring in Greater Manchester South, or is it because that coroners are writing more reports in these areas, or that more preventable deaths are occurring and there's more lessons to be learned in these areas? So there's lots of questions, research questions that needs to be answered. And MPs, I'm in touch with a lot of MPs across the country who will often ask me, oh, Georgia, why is my area all of a sudden getting a lot of these reports written? We don't have the data linked to be able to do those analyses yet. And that's obviously being because we've had no funding and no support to actually create this. But we're hoping that that will change over the next coming months and years as funding starts to change. The other aspect is the responses. So who's responding to, who's providing responses to these reports and having these published online. So I mentioned earlier that in December and January of last year, we worked on a sort of audit with some coroners across the country. So it was, the response rate was sitting at about 33%, 1 in every 3 report had a published response. We saw this big increase, which was very exciting from looking at coroner. I've been looking at coroner data for 5 years and never seen such a positive increase or impact. And we can actually monitor that now that we have data to look at this. So through monitoring what we were doing this intervention, working with coroners, we did see this quite substantial increase in number of reports that have been published online. And that has steadily increased over time. We are at only 47%, so we're not at 100% or 90% because we know that some reports are not yet due for a response. But this has sort of been over the last 12 months. We've been really monitoring these response rates. We've been looking at this for some time, but we've had this graph only since August last year. So nearly 12 months of monitoring response rates to coroner reports, and we are seeing this positive increase in the number of responses that we're receiving. Today, I guess we have some exciting news that we have launched a new tracker onto the website. This has been a tracker that I've been working on for a long time and cleaning a lot of data, but it's the first tracker resource database that actually looks into who receives these reports. So no one in the country, the chief coroner, no one actually knew who was receiving these reports. We've now created a new tracker called the Regulation 29 addressee tracker. And the reason for Regulation 28 and Regulation 29 is just got to do with the legislation behind these regulations. So this new tracker we launched today, we published this website today, so everyone can go and have a look at that. Here we can actually start seeing, well, what organizations get these reports? Do they respond? What are they actually doing with this information? So here we can see that the Department of Health and Social Care, NHS England, and the CQC have received the most of these reports. I have been working with these organizations for some time and met with many people from these organizations to talk to them about PFD reports and what they actually do with them. There's a lot of discrepancy between whether they actually use them, what they do with them, and there's across the board no real tracking system within these organizations to really know how many reports they've received. So not until the last sort of year and a half, these organizations have actually started to track this information. And that's mostly because of the conversations that I've been having with these organizations around, well, how many reports have you actually received? So we built this before we asked these organizations about their reports and how many they've received. And it's very clear that there's no system in place internally in these organizations to actually monitor and use this information in a systematic way or a centralized way. So today, if you're interested, I have written a small article about the launch of this new Regulation 2019 tracker. And I thought it was perfect timing for this webinar to share it with you all and ask questions and talk to you more about. We've got lots of new analyses that we'll be doing with this new tracking database. So in addition to the database, in addition to these databases and these analytics that we provide on the website, we also use the databases to conduct research. We share newsletter alerts, updates, and this is all made possible because we've created these reproducible methods that can be replicated over and over and again in a really efficient way using computer programming. Or as I like to say in lay terms, we've established this research recipe. So we've trial and tested it many times, and we've used it to look at lots of different types of areas of deaths across healthcare and also outside of healthcare. The sort of example I wanted to share, which may not be relevant to pathology per se, but it's really what made me publish the database that we'd created as a website. So it was in late 2020, it was winter 2020, we were going into our second lockdown. And I was doing my PhD focusing on opioid deaths. So I was going through this database, trying to identify every single coroner report that had mentioned an opioid drug. However, I came across many different types of deaths, and I couldn't believe that I was the only person in the country that had a database that could do this, as well as was the only one that was reading these reports in a really systematic approach. And I came across this case from 2013 of a 30-year-old woman who was in a mental health facility, and she had intentionally consumed alcohol-based hand sanitizer. I was going through a few years of the database and I came across a similar death, but 2 years later in a 76-year-old man in a tertiary care hospital. And he had accidentally consumed the hand sanitizer and he'd had a history of confusion, and there was a potential diagnosis there for Alzheimer's dementia, and he was in hospital for various reasons. If the lessons and what struck me in comparing these two cases what the concerns that the coroner raised in 2013, if they had been implemented not just locally in that local hospital, but at a national level, if there was a national system in place for this information to be shared and disseminated across all trusts in the NHS, and for changes to be occurred not just in mental health facilities, but in all tertiary care hospitals, this life of this 76-year-old man could have been saved if there wasn't readily accessible hand sanitizer at the foot of his bed. So these two cases were sort of really fundamental in why I wanted to create the tracker and make it an open resource platform that anyone could go on and use for research purposes or to learn lessons following inquests. And there wasn't anything like this available at the time. The other aspect to this case is also we were the second lockdown. There was hand sanitizer everywhere, and there was sort of 3 key at-risk groups around potential deaths that could be occurring from hand sanitizer. There's children, so lots of facilities, not care homes, but care facilities for children, where they could have increased access to hand sanitizer, as well as in care homes, increased access to hand sanitizer, and those that may have substance or alcohol misuse disorders were trying to access alcohol. And there were cases from America with Trump telling everyone to drink all sorts of things. So it was a sort of time where this case became relevant, even though they were from many, many years before these 2 deaths had occurred. So that was sort of the first published case series that I did using the tracker database, but then had moved on since then and looked at lots of different types of deaths. So on the website, if you go to the research tab, you'll see we've published more than 25 research studies. We have about 4 or 5 papers under review at the moment. So by end of the year, it'll be more than 30 different areas of research. Here is where we looked at deaths involving cardiovascular disease and anticoagulants. I'll just some examples, but as I said, there's many examples on the website. We did a big piece looking at deaths involving medicines. This was replicating previous work that Robin Ferner and Anthony Cox had done in Birmingham, where they'd looked just at a subset of 500 reports, and we expanded that to look at the entire database. And the key finding here was that opioids were the most common drug reported by coroners in these reports. We then looked at falls. We've also looked at sepsis. We've also looked at opioids, which is sort of the founding project that really started all of this research. And during COVID, we used it to look at deaths involving SARS-CoV-2, not just where the cause of death was from SARS-CoV-2, but where the coroner also mentioned other aspects from the pandemic where lessons really could have been learnt from lockdowns, accessing GP services, and many other sort of lessons that coroners raised during inquests during the pandemic. In addition to publishing academic papers, I also write about different cases based on what's happening in the media or in the news at the time. So last year, the UK government banned or made it illegal to use nitric oxide. And so immediately we can go into the database, and we have a machine readable database where we can use keywords, and we can search for different words like nitric oxide and try and identify all cases around the sort of trends of the season or deaths that might be occurring and hotspots, and analyze sort of this routine analysis around issues that might be occurring. We've done the same to look at the XL bully ban that occurred last year as well. So yes, we focus on healthcare, but also many other sort of public health, as well as outside. We've looked at transport, we've looked at cycling-related deaths, and we can use the database to look at all types of preventable deaths that occur. Here's the example on cycling-related deaths. We published this a few years ago, so it is a few years out of date, but it just goes to show the sort of breadth of different types of deaths that are reported by coroners. We've also used the database to work with the media. This was a piece that we did with the Times. It was published in January of this year, but we worked with them last year. I'm constantly getting contacted by people from the media wanting news stories. And in addition to working with the media, I also work closely with the Chief Coroner's Office and was invited to give oral evidence in Parliament in February to the follow-up inquiry to the Coroner's Service. This did lead to the publication of a letter that was published at the end of May, as the election was called, and really sort of speaks to the government around the reform that's needed, particularly around the data aspect. So about 1/4 of that letter is focusing on all of the work that I've been doing over the past 5 years, and sort of calls on the government to fund this work from a national level as well. So that's sort of what we've been using the data to do over the past few years. But in my role before I moved to King's, I was hired at Oxford to run some of the medical programs in evidence-based medicine for the undergraduate medical school at Oxford. So most of the work that you see published has been done by medical students at Oxford, and these reports that they're reading, they keep telling me how much it's really helped them and helped their medical education. So the reports within the tracker are being used to help educate the next generation. And the medical students often say to me, Georgia, I would never want to be named in one of these reports. And so they're a real learning resource and education tool for medical students as well. In addition to the work we do, we can also be commissioned to conduct bespoke analyses of PFDs. This can either be a sort of monthly or quarterly subscription for tailored content, or we can do sort of full, and I've worked with different organizations from law firms to charities, where I've done sort of bespoke, customed analyses based on different cases that coroners and different organizations may be working on at the time. So this is the newsletter Substack that I run, so anyone can sign up for updates about the work that we're doing. And we've got lots of articles in the catalogue as well, in the archive, where you can read about different aspects of coroner death related topics that I often talk about. But to finish on a sort of potentially positive note, I should have said that I have come over to the UK 7 years ago from Australia. And this is sort of the other underlying reason and for creating the Preventable Deaths Tracker. But in Australia and New Zealand, there is a database called the National Coronial Information System, or the NCIS. This is a database that has been running for more than 24 years. However, it doesn't exist in the UK at all. So this is sort of what also was my inspiration for creating the Preventable Deaths Tracker, to try and create something. It's not as good as Australia's, because Australia looks at all Australian New Zealand data looks at all inquests. We only have that 470 reports every year, but it's better than nothing. Otherwise, we don't have anything to learn from coroners' inquests. But Australian system gather this data in this national centralized database. It's funded by justice departments, all the different justice departments across the different states. And it's funded centrally as well. Different government departments, those government departments that fund it get free access, obviously, to the data. It's set down in Victoria, in Melbourne, and in addition to the data itself, they also have a unit that routinely analyzes that data and informs policy. So there is no need for these prevention of future death reports, because there is a national system in place to A, collate all of that information, and B, to actually routinely analyze that and use signal detection and all sorts of other methods to inform policy. So my plan, not just with the King's Prize Fellowship, but moving forward, is to work on building this ideal system for learning from all inquests. So the Preventable Deaths Tracker is just part one, where we've collated and built a system for prevention of future death reports. But we need to expand this to all inquests, where we have a national centralized system, a central database like the NCIS, where we can learn from all inquests, data from all inquests, and collect data from all death investigation. That data, once it's in place and is there and can be used, we then need to have this independent research unit. In Australia, it's called the Coronial Prevention Unit. Canada has a similar one as well. Different territories across Canada have a similar structure where they have this systematic way to inform policy and learn from preventable deaths. I will finish there, but I look forward to answering your questions. And thank you so much for listening.
Well, thank you very much, Dr. Richards. That's really good and interesting to see that. We've already got one question waiting in the Q&A, if I can just ask you that. It says, making systematic use of reports is a considerable contribution to epidemiological studies, but they really require systematic sampling and measurement. And given the various variations there are in coronial practice, and how do you ensure that this isn't happening in your geographic studies?
Yeah, fantastic question, and one that we haven't yet been able to answer just out of a resourcing issue. So there is ways that we can link the coronial data to already available national open statistics. So if we were able to control for, and we do this in some of our studies, where we look at, for example, opioid trends over time. So we look at the number of opioid deaths every year that are reported by coroners, and then we control, or we divide that by the number of reports written that year by each coroner. So we can control for coronial variation by using the denominator of number of reports written by each coroner. So we can control for that from a sort of epi perspective there. But what we do really need to do to enhance that is to have national funding to do research into the coroner service. So there is no national research funding available to ask these questions around geographical variation. And that was the main theme that came up in the inquiry into the coroner service this year in Parliament. So the main questions that the MPs were asking us was, why is this the case? And we really couldn't answer. Well, people were answering and giving all sorts of answers. They weren't evidence-based answers because we don't have the data that's yet linked to be able to say, okay, why are coroners in Manchester writing so many reports? Is that just because they like to write these reports? We could answer that if we had data linkage and we actually can start talking to the coroners and understanding what's their threshold for writing reports. When did they decide to write a report? We could actually compare. I've got a PhD student looking at suicides in London, and she's comparing suicides that have a report written and that don't have a report written to try and understand what's driving this variation. And that's just a London-based PhD, but will have lessons for expanding across the country around why some reports are written for different types of deaths and not others. So there's lots of questions that can be answered. We just need funding and resources to do so.
So I think you're making a case for coroner education and training, not that they will want to hear that, but that seems to be it. It was interesting you talking about Australia and about how you all come together in the various organisations and states there. And one of the problems we have is now we seem to be busily divorcing ourselves. So you're talking about England and Wales, but what's happening in Scotland and Northern Ireland, for example? Are they doing the same thing? Do they have the preventable death reports that can be brought together?
Yeah, great question. So I'll start with the coroner education and training one first, just your comment about that. So last year I was invited by the coroner training lead to give training to every single coroner in the country. So as of February this year, I've now met every single coroner in the country. They all know about the Preventable Deaths Tracker. Unless they're a new coroner that started in the past few months, I wouldn't have met them. So I met every single coroner, presented to every single coroner, and spoke about these issues and spoke about the data. But that was sort of just the start of a training. That was sort of a whole year of training, but it's just the start of introducing them to data and all of that. So there is a lot more of work that can be done around training, even just small things about reporting the age of the individual, which is so often not reported by a coroner, which, as we know in healthcare, is a fundamental demographic piece of information. that really helps you immediately know a lot about a patient once you know their age. So basic information like age being missing is a real sort of bias, I guess, in the data. So current age, definitely I have met them all, but that's sort of an ongoing relationship. Moving on to other places in the UK. So I'm not familiar with the Scottish or the Northern Irish system, but I do know that they don't have prevention of future death reports. It is just a piece of legislation in England and Wales. I did recently, or a couple of months ago, speak at an event up in Scotland, and I was getting a lot of questions about this. I don't know what system is up there, but I do know that there are no PFD reports and there is no national database of any sort like the one I've created or one like Australia and New Zealand. I have also had contact from people in government in Scotland who have been asking me for data. So that also reinforces the need for data in Scotland as well, because I've been asked by people in government in Scotland for data. They want to know about this because England and Wales is now the only two countries that have it in the UK. So there is a lot of work to be done across the UK in terms of getting data from coroners.
Right. How do you think the Royal College of Pathologists can help you with this?
Great question. Well, the first bit is sort of just awareness that this data exists, and it could be a really useful learning resource as well. So I've spoken at other Royal Colleges in the past, and sort of some insights or some ideas that have come out from those discussions have been the potential interest of sending sort of a monthly alert around to members in the Royal College around types of deaths that are occurring, which may help inform your practice about new cases that you might be seeing. For example, nitazines is a big issue that's occurring at the moment in time that I'm involved in some work that's occurring on at King's around sort of the increase in synthetic opioid deaths and those sort of things. So there are some sort of educational perspective around there in terms of the Royal Colleges that may be useful. But I'd also really welcome any feedback or insight that you have around how you think it could be useful. So I would sort of hand that question over to you, and but any sort of lobbying or raising awareness is the first thing that comes to mind. But very happy for your feedback around how you think it could be more useful.
Well, certainly one of the things we're trying to do is raise awareness. I first came across you at the London Toxicology Group meeting, and I knew about prevention, the actual what coroners had to do, but I had no idea what happened to those, whether they just got filed somewhere. So it was a real eye-opener to see what you were doing and to hear that there was more being used, more use being made of this data, because there's no point in just putting it in a file and forgetting it. It needs to have something done about it. Anyway, there's a couple of other questions have come in. Let me see what we've got here. Well, someone's asked, are there any particular areas or series of cases of preventable death research where you think the current feedback system has had a positive impact? Well, I think you've actually given us a couple of examples of that. I don't know whether there's anything else you want to say on that, or whether you feel you've covered that.
Yeah, there are a few, we talk about this in our individual research studies. So the opioid cases and the falls, and when we go through each individual type of deaths that we're investigating, we do look in to see what organizations say in their responses and what action has been taken. And the sort of few examples that come up are around sort of guideline changes. So if there's a new drug-drug interaction or sort of prescribing guidance, there has been positive changes from both the BNF perspective as well as a NICE has actually created new guidelines following these reports. So we do see positive impact from the reports, but often in a sort of holistic perspective, if I look across the entire database, what usually happens or what usually needs to happen is this sort of ideal recipe for change. So a great example is the case last year. It's not too healthcare related, but it was the death of Ruth Perry, the head teacher last year. Her inquest, it concluded in about November, December last year. And at the same time as her inquest concluding, the coroner wrote one of these prevention of future death reports. But also at the same time, there was a new head of Ofsted. There was a change in leadership. There was a lot of media reporting. And so they usually, for actual, real, meaningful change, like Ofsted stopping their investigations immediately, to have real, immediately timely action that's taken, it often needs more than just a PFD report. It often needs a lot of media attention, a change in leadership, a lot of different factors to align for real change to really happen. And I think that's an unfortunate situation and scenario of PFD reports, because no hospital trusts want to get these reports, and they're really seen as such a negative, a real negative aspect, whereas they're not seen as this learning opportunity to actually make change. And then for that trust to shout about the change that they've made and share that change with all trusts across the country. So there is this real sort of shame connected with these reports. And so no one really talks about what they do after the report. No trusts share the data that they get. No trusts share what lessons they could have learned. It's very much so a local learning, if any learning. It's voluntary, really. Whereas there is this missed opportunity for a national learning, unless there is that media attention, an MP involved, a parliamentary question, or sort of a real sort of force behind it to get change. And I think that's a real disappointing aspect of these reports, that it takes so much for one single death for anything to happen. And most of the time, nothing really does happen.
Great, thanks very much. So questions are coming in thick and fast now. Let me just quickly have a look at those. Right. So, question here about not to be too specific, but we're looking at other groups of deaths, for example, decomposed bodies. I'm not quite sure where that links through to this. Really missing from the system. The people who die at home and sometime before anyone notices they've died, and therefore potentially prevention, if there was some theme that they were not contacted regularly prior to death. I don't know whether that question, Nick, whether you can answer that, or whether that's a little bit outside.
Yeah, it's I haven't seen many coroners talk about this issue in terms of decomposed bodies, but I think in terms of just general evidence, obviously that's going to have an impact on, for example, toxicology, on what really can be done and what evidence can be collected from those sort of cases. It's not come up as a common theme in these reports, but again, I'm sure, yeah, it does have a huge impact on the quality of the data that's collected from these deaths.
So do you think there's similarities of what the CDC are doing in the United States in relation to drug-related deaths, of correlating that?
Yeah, so the CDC is similar. I would say I would align the CDC's work with what the ONS does, and this is sort of the real issue we have in public health epidemiology. So public health epidemiology, including CDC, like ONS, collect data, mortality statistics, and that mortality statistics is great for, and is really essential, obviously, national statistics in terms of knowing the national perspective of these deaths. But what the national statistics don't help us do is understand the circumstances of death. So public health epidemiology use national statistics. They also use electronic healthcare records, and they'll tell you how many people have died on what prescriptions, etc. But the key thing that the coroner data does, which these other national statistics don't, is they tell you what happened and what sort of concerns were raised during the death investigation process. So they really give you a rich insight into what actually happened in the lead up to these deaths, and what were the potential failings or mistakes or things that might have occurred, that really gives that lesson, that picture around sort of what lessons can be learned, which the national stats don't do. So I would say, yes, the US is great because it's got the CDC, but They have a very interesting coronial system. It's obviously very variable based on state by state, and they also don't have a national or state-based sort of data learning structured system from coroner data. There's very few countries in the world that are actually using coroner data, and the power of that coroner data to really inform public health just hasn't yet got to that stage that we're seeing in countries like Australia, New Zealand, and Canada.
I think your presentation has really highlighted how much information we're wasting. There's a couple of questions on the Q&A about drug deaths, and I don't intend to address those or ask you now, because we've got a webinar coming up in September where Caroline Copeland will be talking about the National Programme on Substance Use Mortality. So really that's something that should be held in reserve for that webinar, and that will be very interesting, where we're actually collecting data on drug deaths in particular. And Caroline will present that information in the September meeting.
Yeah, I should say with that, so Caroline is my line manager at King's. So I've joined Caroline's team and the whole team that run the NP-SAD database, that is the drug-related deaths database. So our databases are similar but different in the sense that Caroline's is collecting all of the toxicology data from all deaths in England, Wales, and Northern Ireland, and she'll tell you all about that. And that's drug-related deaths, whereas my database is just England and Wales. It's a much smaller database because it's only the data are where coroners actually write these reports. But my move to King's and joining Caroline's team is that we're going to be able to link the Preventable Deaths Tracker and all the data in there with all of Caroline's toxicology data in the NP-SAD database. So that's sort of where I've moved to at King's. So we're a great combination, a great team to be joining forces.
Yeah, and that's another database that's grown out of individual effort rather than government. And it's surprising that the ONS doesn't want to pick up some of this information, as it seems to be a perfect piece for national statistics. Do you think in the death tracker there's a bit of a name and shame possibility there? I mean, the CQC has been in the news recently, and I noticed the quick when your slide came up, CQC was up the top of things that are going to it, reports that are going to it. And I just wonder what they've actually done. My interactions with the CQC have been less than satisfactory, I have to say.
Fantastic question. So it wasn't, when we started out to build the website and the different pages, it wasn't there to name and shame, but actually that's sort of what we've had to resort to in the sense of the recent Regulation 2019 tracker, where we are putting organizations' names up there now to say these are the organizations that receive the report. So A, can they help us fund this? B, can they do something about this? Are they not interested in this data? Do they not want to know what, like, they don't, these organizations don't even know how many reports they've received. And I know that for a fact because I've just done a series of hundreds of FOI requests to ask these organizations how much data they have on this. And it's been a very interesting learning process, A, through the FOIs, and B, through speaking with these different organizations. So there is a great Cochrane review that looks at not sort of naming and shaming, but this sort of nudge technique where you sort of create this systematic way, this robust research way to actually look at engaging with organizations using data and seeing how that actually leads to organizational change, these sort of nudge processes. So the tracker is using a bit of that now because we've just had no movement from these organizations, and I've been meeting with them for nearly 2 years now, and there's been no change and no sort of action. From the CQC, I've had very interesting conversations with people at the CQC. And I think what the most interesting and shocking sort of discovery was that when I started attending the coroner trainings, coroners would actually say, oh yeah, if I send 3 of these reports to an NHS trust, the CQC will take action and will go into the trust and investigate what's happening. That is completely myth made up, because then I went to the CQC and said, oh, is this true? And they said, oh, no, that's not true. And I was like, so what do you actually do with these reports? And it took them months and months and months to actually come up with a logical way to say, this is what we do. So I don't think, well, the conclusion of all of that is the CQC don't do anything with these reports. So coroners can send report after report after report to the CQC and nothing will happen. And that's the reality. But the concerning bit is that coroners had faith in the system and they truly thought that sending a report to the CQC would lead to action and investigation, and it just doesn't. So there's a whole accountability, transparency issue from not just the CQC, but across all of these public health organizations, where there's just no transparency around what's really happening with these reports and what action is really taken. So there's a lot of work that needs to be done, and the CQC is a sad example of the reality of the situation.
Right. Let me just have a look at this. There's several questions now in there. Okay, let's right. There's a question I don't really understand in here, which says sometimes bodies received for post-mortem are quite decomposed, and often the cause of death is not established. Toxicology is not possible. Well, that's not true. What is the perspective when these type of post-mortems can be stopped from the coroner's side? I'm not sure you can answer that question because you're not a coroner, I'm not quite sure what it means anyway. Yeah. What about individual hospital departments? I mean, they're sent to trusts. Do you think individual hospital departments should be getting these as well as the trust? So trust hierarchy and the individual departments concerned should be getting them.
Yeah, I would say I think the coroner's role. So when I talk to coroners about this, I say that the tracker is also being built to reduce the burden on coroners needing to send reports to multiple individuals. What really should be happening is coroners shouldn't be sending the reports to anyone. There should be a national way that this learning can occur without coroners having to email individual people, different trusts, different departments. So because coroners are writing these reports and then having them to email them, and those organizations have to read that email, do something about it, write a response and email it back. Then that email, the coroner then has to get that email and send it on to the chief coroner's office by email, and that then gets to publication. So the number of emails that have to go back and forth between a coroner office and the organization and back is completely inadequate for a system that's meant to be saving lives. So the fact that if that email doesn't get sent, someone else could die is quite a scary reality. So I think the whole email-based system is a huge flaw. And I think that is really also what needs to change. And this is why you need a national centralized data system so that individual hospital departments could find out about this information if there was investment for routine analysis where there could be they could learn about this information through other means where they wouldn't need to read 5,000 coroner reports to learn something. There could be a really structured, sort of tailored approach for each hospital department to start learning from coroner data. So the whole email-based system, I think, is a huge flaw of the system and should really stop as soon as possible.
It's partly, I guess, a problem of sending it to someone anonymous. It's a bit like when what you're taught to do when you're resuscitating someone in the street if they've keeled over and they need CPR, is you point to someone and you say, call an ambulance. And then they have responsibility. And without responsibility, it just goes into a mess. And as well as that, I think emails are all very well, but I don't know how many emails you get a day, but I get a lot, and it just sinks to the bottom of the pile. If I got a recorded letter with my name on it, and then you'd know the person got it and the person has seen it because someone has to sign for it. So anyway, I think we're coming to the end of our time. So thank you very much, Dr. Richard, for doing that. That was a really useful presentation from my point of view, and I hope it was from everyone else. And I hope it's showing that the speciality committee for toxicology isn't just sitting on our hands. We're actually trying to do something and increase the education of our members in the RC path, and for other people who are able to log on to this through the recording that we've got. And if I can remind you again, we've got Caroline Copeland and the National Programme of Substance Use Mortality coming on in September. And that will be, again, will really add to what you've already shown us and shown why we should be getting that data together, because that's important. So if I can thank you again and thank everyone who's tuned in to listen to this, and hopefully they've got something for it. Thank you very much, George.
Thank you.